Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by SurvivingBreastCancer.org. I'm Laura Carfang, breast cancer survivor and founder of SurvivingBreastCancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Welcome to another episode of Breast Cancer Conversations. I am so glad you are joining us, whether it is your first time tuning in or you are an avid listener. Welcome back. We are so excited to have you here today. Before we get started today, I would love to send out a huge shout out, lots of love, and a heart filled of gratitude to our sponsors making our podcast possible through our partners at GE Healthcare. So thank you for always supporting the work that we're doing at SurvivingBreastCancer.org and our podcast, Breast Cancer Conversations, where we're always bringing the latest and greatest in education, community, and resources. I am pleased to be joined with Dr. Dehdashti, who is board certified in nuclear medicine. She is Senior Vice Chair and Director Division of Nuclear Medicine, Drs. Barry A. and Marilyn J. Siegel, Professor of Radiology, Mallinckrodt Institute of Radiology at Washington University in St. Louis. She is the co-leader of Oncologic Imaging Program of the Siteman Cancer Center. This program's main focus is in translational research studies in all fields of imaging. She is also the PET Medical Director of the Center for Clinical Imaging Research, a center for PET MR and PET CT research imaging. Dr. Dehdashti has been involved in translational PET research and interpreting PET imaging studies for over 3 decades and has many publications supporting the use of PET in clinical oncology. Her research has focused on translational oncologic studies with an emphasis on receptor imaging, specifically estrogen and progesterone receptor imaging tracers in breast cancer. She has designed and executed many clinical trials, in particular, the first human use of a variety of novel radiotracers developed at Washington University.
At the time, PET was only used on research. And so when I came here and therefore got involved with research and learned about FES, that was the time that it was just translated to human. And there were a group of patients with primary breast cancer were studied with this agent for the first time. So when I saw the image, I remember I was just amazed to see actually, what I'm looking at is estrogen receptors in the breast cancer, something that I didn't, think is possible. And so I just was so amazed that I wanted to learn more.
Welcome to the conversation.
Thank you so much for inviting me. This the research that led to really FES or Cerianna to be approved. It goes back, as you mentioned, almost, I can say, from the time it started till the time that it was approved for clinical use, probably 4 decades. So I should go back to why actually this tracer was developed. What is unique about estrogen receptors? I mean, a lot of you probably knowing about estrogen receptors, but I just want to review a little bit of the history of estrogen and estrogen receptors. And I should say that long time ago, in probably in late 1800, people started to understand the importance of estrogen hormone that is, found in our bodies. It is produced by our ovaries. And they found that it has a remarkable stimulatory effect on the uterus and breast. And it showed that in patients who have breast cancer, at least in some of them, if they remove these ovaries, they can treat breast cancer. And so after a while, they realized that this hormone has to be bind to some sort of receptor. And then it was really until the late 1960s that they discovered estrogen receptors, and they started using some sort of in vitro assays to measure them. Estrogen receptors was recognized to be very important in breast cancer, because patients who have ER positive disease, they have less aggressive tumors and they have better outcome. And these tumors are the ones that can respond to anti-estrogen therapy, and which we know that most breast cancer have actually estrogen receptor positive disease, and therefore their tumor is dependent on estrogen for their growth. And it was in late 1980s, because of the importance of estrogen receptors, Dr. John Katzenellenbogen from University of Illinois became interested in developing tracers, agents that can be used to image this receptor. And he collaborated with late Michael Welch, Dr. Michael Welch, from our university, Washington University, Mallinckrodt Institute of Radiology, and they developed several estrogen receptor imaging agents, and they tested them. And what they found that this FES, which is F18 estradiol. F18 is the radioactivity that is attached to estrogen hormone, which is the estradiol part of it. And the commercial name of it is Cerianna. So they developed that agent, and they felt that that is the agent that can be successful in humans. They did, testing. They make sure that this is not toxic. It's not going to change anything, any hormones in the patient's body, and therefore it was translated into human. When I came to WashU, one of the reasons that I went to WashU was that I knew that positron emission tomography, or PET, is a modality which is very important in research and has a potential to become clinically also important. So, and because PET was developed here at Washington University, I thought that this is the perfect place to go and learn about this modality. So at the time, PET was only used on research. And so when I came here and therefore got involved with research and learned about FES, it was that was the time that it was just translated to human, and there were a group of patients with primary breast cancer were studied with this agent for the first time. So when I saw the image, I remember I was just amazed to see actually what I'm looking at is estrogen receptors in the breast cancer, something that I didn't think is possible. And so I just was so amazed that I wanted to learn more, and therefore got involved with a subsequent evaluation of this tracer. We did a lot of different types of research studies. We made sure that the binding of estrogen receptor and estrogen is unique, and you can actually block it by giving anti-estrogen to the patient. And we evaluated a large group of patients with not only primary breast cancer, but also with metastatic breast cancer, recurrent breast cancer, to see that if we can actually see all these lesions. And we were successful seeing all sorts of lesions. The only area that is a limitation of FES is really liver, because FES is excreted through liver, and there is always very high uptake of FES in the liver. And therefore, tumors that, metastatic disease in the liver, we have difficulty really seeing it. However, if the lesion is very big, you may see it, but it often has activity less than normal liver. So it's very difficult to know the status of receptors. And I have seen, tumors that have the biopsy was ER positive, but the image was negative in the liver. So liver is one of those areas that we can't really depend on FES truly to judge about the receptor status. But the rest of the body, everywhere else, I think FES is really a very unique tracer that can help us see the entire body, all the lesions, and see if they have receptor status positive or not.
Why is imaging so important?
Nowadays, everybody who is diagnosed with breast cancer, a tissue diagnosis is needed, and therefore after that they do estrogen receptor, progesterone receptors, HER2 status. All of that is measured. So why is that is not enough? So the reason that is not enough, that breast cancer is heterogeneous. It's the cellularity is heterogeneous. So we are only analyzing a small piece of one lesion, and so it depends on where we're getting it. The result may be different. And in addition, we're only evaluating one lesion and not the rest of the lesions. Even in the initial diagnosis, it is possible that the metastatic disease, if the patient has it, have different receptors than the primary. And especially if when the disease comes back, that is about 15 to 20% of the patient may not have the same receptor status. Or the lesions, if there are 10 lesions, maybe 5 of them are receptor status positive and 5 of them are not. And with biopsying one lesion, there is no way that we will know that. So that is why imaging is very important. Imaging gives a better picture of what's going on in the patient body, and help the oncologist decide what is the best way to treat the patient. So that is why I think I'm drawn to this modality, and I wanted to learn about PET. I wanted to learn about this special tracer, although my research is in PET in oncology, and I do other receptors. I do other diseases that I research, but I think breast cancer is something that's very close to my heart, and I always wanted to learn more about it. So moving on with, FES, we wanted to know, after we knew that we can actually image all sorts of lesions, we wanted to know if we can predict response to actually therapy, to anti-estrogen therapy. And so what we found that the baseline FES, the FES that you get before therapy, actually is very strong in predicting response. The way we learned that patients who have low FES or no FES uptake, those are the ones that are unlikely to respond to endocrine therapy. However, patients who have positive FES, they are not all of them going to respond to endocrine therapy, but most of them will. And so if you look at in vitro assays tells us that about slightly more than half of the patient with ER positive disease actually respond. And when you take that group of patients, which we did, everybody who had ER positive disease, we studied them with FES, and we found that among that, there is a group of patients at negative FES, even they had ER positive in vitro. Those are the ones that are not likely to respond to therapy. And the rest of them, most of them will, but not obviously all of them.
Just as a clarifying point too, I think you mentioned a couple of things that sparked my interest. One being, would this be something that someone would have an FES PET prior to their initial treatment, or is this something that is provided after they've already been given hormonal therapy? So I'm wondering, where in the process would someone actually opt and advocate with their oncologist to get this type of imaging? And then the second thing you said that was intriguing was that, let's say we have 10 metastatic lesions. 5 perhaps could be FES and light up and show that they have these ER receptors, but if the other 5 do not, would an oncologist or a doctor, in combination with your consultation, give treatment for both? Or how does that play out actually in that clinical setting?
FES or Cerianna is approved only for metastatic and recurrent breast cancer. So you really, at the present time, you cannot use it for primary breast cancer when a patient is diagnosed. We need to do more research in, regarding FES to learn how to use it in primary breast cancer. We have used it in research and it worked well, but it is not approved. So therefore, the patients can't, ask about it because the insurance companies are not going to pay for it. It is only in the recurrent and metastatic setting that is approved. And I think if you think about primary breast cancer, as you know, we have a lobular breast cancer that is a smaller percentage of breast cancer. Mostly, they're being ductal. So lobular cancer is one of those breast cancers that is very difficult to detect with all our imaging modalities. The way it grows is just very difficult to know the extent of disease, where it is. And for those patients who have ER positive disease, which most of them are, FES has shown in research studies that it's really helpful, but it is not approved. So we have to work on that group of patients, do more research to show FDA that, hey, these are the patients who can benefit the most, among the group of, primary breast cancers, for example. So we have a lot work to do still while FES is positive. I mean, is approved clinically. We have to show that exactly how it can work in all the stages of breast cancer. And then if the patient has heterogeneous, group of lesions. I mean, that I'm not an oncologist, so I don't know exactly what they do, but I think they probably cover both the endocrine part and non-endocrine part with, these days they combine all sort of therapies. Yes. They do endocrine therapy with other targeted therapies that can target ER negative and the same time as ER positive. It just, I think, give oncologists a little more idea that how to treat maybe the best way these type of breast cancers. The thing is that this is kind of new to oncologists because before they had no idea that the patient will have both type of lesions. But now that we're using FES, this is the first time they're also faced with this fact that how we're going to treat them. Exactly. What is the best way to treat? So hopefully this will lead to a better, treatment and management of breast cancer.
Yeah, my very simplistic analogy has always been like, after like Thanksgiving or some of like the major holidays here in the US, right? Like you have the pie in the refrigerator and you go in and you want to take out a little piece and there's like a corner that has mold on it. And you're like, oh, I definitely won't eat that corner that has the mold on it. But what about the rest of the pie, right? And so that's what I think when you go and get your biopsy, right? They're just taking exactly what you're saying, a portion of the tissue and making very important decisions on your treatment plans based on that information. And what I'm hearing is that FES can give a broader picture in the metastatic setting and recurrent setting.
Yes, exactly.
Dr. Dehdashti, what else do we need to know about FES PET?
I want to also mention that, FES is a wonderful tracer and we need to learn more about it. But one of the fact that we cannot identify exactly the group of patients with FES positive, ER positive, and FES positive, that going to respond to therapy raised an important question in our mind that maybe the receptors are present, but they're not functional. And so that led to my second, series of research that I did with my collaborators, and how we can actually measure the function of estrogen receptors. So we started with the fact that, when estrogen and estrogen receptors bind together, if it is functional, then it will initiate a series of events, and which the end result will be the growth of breast cancer. And those are the ones that are dependent on estrogen for their growth. And this growth will cause increase in glucose metabolism, increase in protein synthesis, increase in DNA synthesis. And also it will increase progesterone receptors, because progesterone receptors and estrogen receptor are connected. And patients who have both estrogen receptors and progesterone receptors, the assumption is that they are more likely to respond to endocrine therapy. So therefore, we decided first to start with glucose metabolism using FDG. So the first study we did was with tamoxifen. So we got a group of patients, had FES and FDG at the baseline. They went on tamoxifen, and then 7 to 10 days after, we studied them again with both FDG and FES. So tamoxifen is a unique anti-estrogen. It has estrogenic effect initially, the first 7 days. And then after that, the anti-estrogenic effect of it kicks in. So initially, we measured that. We showed that patients who have functional FES, functional estrogen receptors, they respond, most likely they respond to endocrine therapy. And we identified that group of patients. And we identified the group of patients who didn't have that functional estrogen receptors. They didn't respond to therapy. And then more recently, we did the same study with progesterone receptor agent, which is also developed by John Katzenellenbogen and late Mike Welch, which I've been using it for, in patient with breast cancer, but then decided to use it in this contest and to find out if there is, if we can measure the functional status of breast cancer with giving just a small dose of estradiol. And we published our results in last year. And after that, we got funding from NIH and also from TBCRC to carry on this type of research, but multi-center, which we're working with University of Washington, with the University of North Carolina, to carry on the multi-center trial and to see what we found in our institution is actually can be found in multiple places and go on as something that can supplement the FES and measuring the function of estrogen receptors.
Exactly. And we're always empowering our listeners too. So if you don't know, how I started off earlier today, if you don't know what questions to ask, even, you don't know what's out there. So, if you are listening to this and feel that you might be a candidate, it's definitely worth having a conversation with your oncologist, because knowledge is power. The more information we have about our disease, the more informed decisions we can make.
Exactly. Because, you can't assume that your oncologist knows everything. So you need to bring it up. And if your oncologist is smart enough, we'll go and, research it and learn about it. And if you're a candidate, we'll order it for you. So it's both way. It's our job to teach our oncologists. It's the patient's job to teach their oncologists. So, and we learn from each other. We learn, definitely we learn from oncologists what is important for them. And we try as imagers to find ways to give that information to them. And I mean, for all of this, remember that patients make the most important group of individuals that can help us to really promote, to go forward with all this research. Without them, there is no way we can do anything. You need the patients, and I really thank them. Over years and years of research, having the patients unselfishly participate, while knowing that this study that they're participating may not really benefit themselves per se, but it can, help other women with this cancer. And this is really, it's just amazing. They're hit with knowing they have metastatic disease, for example, and their brain goes 100 places, but then they're also willing to participate. I mean, this is really, really an amazing thing that I have seen and just see it every day.
Well, I really appreciate you acknowledging that. It's something we talk a lot about too in our communities of, trying to educate about clinical trials, the importance of getting involved in clinical trials, demystifying some of the myths and misunderstandings about how clinical trials are run. So I appreciate you acknowledging the importance of the patient experience and their involvement in the science. So thank you.
Yeah, I mean, they make a huge impact in what we know, what we learn about, at least in my field, about these tracers.
Dr. Dehdashti, this has been an incredible conversation. I have learned so much. Thank you for joining us on Breast Cancer Conversations, telling us more about FES PET, Cerianna, how this novel tracer could be utilized in the metastatic and recurrent setting. I appreciate all of the incredible research you and your team are doing, and thank you again for being a guest on Breast Cancer Conversations. And thank you, everyone, for listening to our show. I would like to acknowledge that all of the information on our podcast are from personal experiences and are not a substitute for professional medical advice. You should always contact your medical care team. Our podcasts are made possible because of donations from listeners like you, so please feel free to make a contribution through survivingbreastcancer.org/donate. And there are so many ways to get involved with our nonprofit and our organization, not just through listening to the podcast, but through all of our virtual programming. So you can check out all of our lineups by hopping over to survivingbreastcancer.org/events. And as always, all of our programs, services, and resources are absolutely free. Thanks again and keep on thriving.